All right, let's do it. This is the fourth segment of the breast section, and we're going to be talking about the male breast. Now, there is no more humiliating way to die for a man than breast cancer. But the good news is that male breast cancer is uncommon. The bad news is that when it does occur, it's usually advanced and invasive at the time of diagnosis. Let's just review some normal anatomy really quickly, because there's at least one point here that I think is helpful for the purpose of multiple choice. So in the normal female breast, we've got these branching, elongated ducts with terminal lobules. So the ducts are long, they branch, and we've got multiple lobules. And this is something that, occurs and is developing with puberty and hormones and all that stuff. Now, in a male breast, it's different. There's only a rudimentary duct system, and the ducts end in what some people will call terminal buds. The bottom line is there's no lobule formation. And because there's no lobule formation, there aren't lobular-related pathologies like lobular carcinoma, fibroadenomas, or cysts. Now, here's a way to apply that. If you would happen to get a question like this, which of the following pathologies are present in this mammogram of a male breast? It doesn't matter what they show you. They could show you a picture of shoes. As long as you can eliminate the choices that don't occur in male breasts to start with. So like anything that's lobular related, ILC, fibroadenomas, or simple cysts, none of that occurs in a male breast, so you know those aren't the choices leaving you with IDC. Even if you have no idea what that looks like, you get this question right, understanding that basic anatomy. So just like in other modules, going to be 3 basic types of questions here. Starting off with the first case, let's have a look here. So we've got bilateral MLO mammogram. This is a male breast because it's in the male breast section. Palpable marker is noted on the left. And what we have is a branching, sort of non-mass-like finding that's posterior to the nipple bilaterally. You've got normal intervening fatty tissue seen on both sides. It's symmetric. And this is a very good look for gynecomastia, which is basically enlargement of the normal elements that are present. Gynecomastia can be normal or physiologic in boys under 13 or in old men over 65. If you're presented with a case that has a patient's age between those two, they may want you to interrogate the patient for additional possible causes. So what are the classic causes of gynecomastia that you would want to ask the patient about? The big ones are psych meds, specifically antipsychotics that are messing with like that dopamine prolactin pathway, spironolactone, which is that's probably the number one single drug if you're going to mention it. That's a step 1 question. Cirrhosis, marijuana is somewhat controversial, and testicular cancer. So there's 3 different types of gynecomastia: nodular, dendritic, and diffuse. I don't think that they would ask you to distinguish between the types, but I am going to drop just a few pearls of trivia that could be potentially testable. So the nodular form is the most common. It's centered behind the nipple, radiates posterior as it blends into the normal fat. It can be tender, and it's typically present for about a year once it shows up. So it's not going to go away if you would follow it up in 3 months, which you should never do anyway. But if they would show you that it was present in 3 months, that doesn't mean anything. It usually will last about a year. The dendritic subtype is your chronic fibrotic subtype. You'll note that it branches sort of like a tree, and that's where the name comes from. And this is not painful. Lastly, we've got a diffuse glandular subtype, and this almost looks like a woman's breast. And the thing to know about this is that this is the kind of gynecomastia that you get if you're receiving estrogen therapy. All right, so here's our next case. It's a grayscale ultrasound, and we've got a mass here. Not for sure shadowing, but it does look ugly, right? So right away, you're worrisome. Now, I would expect that the question header would tell you this is a male's breast. If this was a female breast, this is going to be at least a BR4. But I'm telling you now that it's a male breast. So what do you want to do next? Here are your choices. You can either BR4 or BR5 it, which means you're going to biopsy it. You could BR3 it. You know that's never the right answer. There's very specific scenarios for that, right? You could get an MRI. You could just let it go. Or you could get a mammogram, which is the right answer. So when you're working up breast pathology in a man, you always start with a mammogram. If they force you to start with another modality, you should redirect and start with a mammogram. You can't say shit about male breast without a mammogram. You have to have it. Because specifically the nodular subtype of gynecomastia can look scary on ultrasound, and you have to get a mammogram to be able to tell what's going on. So go back to this. So once you see this, the mammogram, if you're going to go down the pathway, you could BR2 this. And it does not require follow-up. Even though you saw that scary-looking ultrasound picture, doesn't matter. You know that gynecomastia can look abnormal on an ultrasound, and you know what gynecomastia looks like, and this is what it looks like. So here's another case. It might be possible to mistake this as a woman's breast also, but I'll tell you that it is a man. He's a very unathletic man who likes to play video games and eat Doritos. He's actually never been to the gym in his life. So this is pseudogynecomastia, or bitch tits. This is a guy with bitch tits. So basically, it's a fat guy. He's a fat guy with bitch tits. There's not a discrete, palpable finding. There isn't actually proliferation of those ductal units, and he just needs to go to the gym. So next case here, we've got this isn't the perfect mammogram, the nipple's not in profile, but we do have a palpable marker that is below the nipple and not really seeing anything behind it. So when you're stuck with a palpable finding, you almost have to do an ultrasound, especially when you're not seeing it. So you see it, it's palpable, looks like gynecomastia, you could let it go. You see it, there's a palpable marker, you're not seeing anything. Just like if you were dealing with a woman, you're going to have to go in and ultrasound it if it's palpable. So gynecomastia would be an exception. At least that's how I would work it up. I would just call it off the plain film and not ultrasound it because I didn't want to get confused with the ultrasound because I know it can look scary. But in a situation here, I'd be afraid that I was missing something, so I would have to go in and ultrasound it. And so you get an ultrasound, and this is what you see. Very discrete finding. Echogenicity is isoechoic with adjacent fat. You palpate it, and it's soft. And this is a lipoma, just like if we were going to ultrasound the back or the leg or something somewhere else in the body, a lipoma is still a lipoma. And in a man, next to gynecomastia, this is the second most common palpable finding. So here's a next case. We've got bilateral CC views, and we'll zoom up here. And this one is going to be different, right? This is abnormal. It's a spiculated mass. It looks scarier. And the big tip-off here is that there's skin thickening. That's not normal. That should immediately tip you off that something bad is going on. And the general tip that I will give you for deciding whether or not you think male breast cancer is if I showed you that same mammogram and I told you that this was a 60-year-old woman, you would BR5 it immediately, right? So try that. If you're on the fence, a breast cancer in a woman looks similar to a breast cancer in a man. Remember that it's always ductal because they don't have those lobular units. The most common presentation for breast cancer in man is a spiculated mass. It's less common to be architectural distortion or calcifications. Although if you do see calcifications, it's very concerning in a man. It's usually an older person. Average age of a male breast cancer is 70. So there are two big risk factors for male breast cancer. BRCA, specifically 2 greater than 1. The way I remember this is breast cancer is more common in a female, that would be 1, and out of the 2 gender types, it's the second most common, so BRCA2. Klinefelter's is the other one. This is sort of a girly man, right? So Klinefelter's is a syndrome that has a high risk, relatively high risk rate of breast cancer. So let's compare and contrast the orange case here, which is a gynecomastia case that I showed earlier, versus the red case, which is, again, obviously a breast cancer, right? You can see the abnormal skin thickening. You can see an abnormal lymph node. So what are the things that make you think about male breast cancer relative to gynecomastia? So eccentric to the nipple, unilateral, although you can have unilateral gynecomastia. An abnormal lymph node is a big tip-off. Skin thickening is a big tip-off. Calcifications are a big tip-off. And probably the most helpful thing is that it just looks like a breast cancer. So lastly, let's just do a little bit of trivia here. Should males with gender reassignment on hormonal therapy get screening mammograms? And the answer is no. Now, obviously, their risk does not approach the screening risk threshold for somebody that should get a screening exam. Not even Klinefelter's do, although they're the closest to approaching the threshold. Now, obviously, if they have a palpable finding, they can get a workup. So don't get it twisted. Palpable findings still get workups, but they're not going to enter the screening pool no matter what kind of hormone therapy they're on. All right, so that's the end. And the next lecture will be an introduction to breast MR, some basic stuff on that.